Good, good afternoon, everybody. So this is a very important topics that I've chosen these topics infecting myself because this is the need of the hour. So I have made this COVID-19 cardiac injury surveillance and outcome in survivors. I'll mainly point out mainly for the survivors, not with the echocardiography in acute COVID cases. I'll highlight certain things. Before that, why I have chosen these topics? Because this is very important to know that just see the burden in the at the moment as on 6 to when today the total case in the world is more than 10 crores. We haven't seen any infection involving more than 10 crore people worldwide in our lifetime. And in total case in India is near about 1 crore. But that is the total number of infected patients. But see the total number of recovered is near about 8 crores in the world and almost a crore in India. So we have to deal with this burden in India in the near future, and there will be many more will be coming in the next few years. See, there is a recent article in the JAMA cardiology study used cardiac MRI on 100 people who had recovered from COVID-19 within the past 2 or 3 months. Researchers found abnormalities in the heart of 78% recovered patient and the ongoing myocardial inflammation in 60%. And the same study found high levels of the blood enzyme troponin, an indicator of the heart damage. In 76% of the patient tested, although heart function appeared to be generally preserved, and the most patients in the study had not required hospitalization. Remember it. So now, the coronavirus disease 2019 pandemic has demonstrated a broad spectrum of presentation ranging from asymptomatic disease to severe respiratory failure, myocardial injury, and the death. And up to 20 to 30% of patients hospitalized with COVID-19 had evidence of myocardial involvement manifested by only by elevated troponin levels. The prevalent cardiac expression of the angiotensin 1 converting enzyme 2, the target for SARS-CoV-5 protein, is implicated in the pathophysiology of the associated myocardial injury. There are numerous studies have shown the AC2 is a cardioprotective transmembrane protein whose expression is downregulated by SARS-CoV-2 infection. There are multiple pathways to myocardial injury. There are anyway, the 1 to 2 myocardial infarction, myocarditis, vasculitis. There are other varieties of inflammation, thrombosis, stress. But depending on the type of myocardial injury, there may be important sequelae if residual inflammation or fibrosis coexist. As SARS-CoV-2 is a new pathogen, there are no long-term data on cardiovascular abnormalities of dysrhythmia that may occur in the convalescent phase. So in a patient with COVID-19, myocardial involvement can be the initiator of a pathway of inflammation and subsequent fibrosis. And the extent and distribution of the fibrosis produce electrophysiological abnormalities that ultimately predispose to atrial fibrillation or ventricular arrhythmias. So these are in a nutshell, is that the SARS-CoV-2 able to affect the heart and the potential lead to these cardiac complications. What are those? Arrhythmias, myocardial injury with troponin elevation, STEMI, myocarditis with systolic dysfunction, pericarditis, myopericarditis, pericardial effusion, tamponade, and pulmonary embolism. I'll try to show you an example of each of them. Unfortunately, all of these cardiac complications are significant and potent significantly increase morbidity and mortality. So these are the basic mechanism. SARS-CoV-2 mainly causing the lung injury, or it can cause a direct viral myocardial invasion, stress cardiomyopathy, or the microvascular or the angiopathy, or the microvascular thrombosis, even the coronary plaque rupture, and of course, ultimately, hypoxia, inflammation, and the inflammation-related injury all lead to cardiac complication. There are certain clips. You can see this is a patient with the acute COVID infection with the fulminant myocarditis, a severe myocarditis, hardly an ejection fraction of near about 10 to 20%. There is a same case with the fulminant myocarditis, another view. A patient with the Takeshibo cardiomyopathy is a patient with the COVID-19, which has been recovered within few days. There may be pericardial effusion, mild to moderate. Even you can see sometimes a small pericardial or mild pericardial effusion, even you can detect in the MRI, and even you can land in pericardial tamponade. There may be, you can see the evidence of pulmonary embolism. You can see the evidence of pulmonary embolism, though it is very difficult to see in the transthoracic echocardiography embolus in the pulmonary artery, but you can see all the indirect evidence of pulmonary embolism is present with the McConnell signs. So early detection and intervention could improve the long-term outcome. Patients with asymptomatic but overt clinical cardiac disease benefit from standard therapy. But patients with subclinical disease may be at risk for late cardiac arrhythmias. Therefore, the identification of the survivors of the COVID-19 infection with subclinical myocardial disease and or arrhythmia create a rationale to consider agents with demonstrated cardioprotective properties such as MRA, beta blockers, and the statins. Given the large number of COVID-19 survivors, enhanced surveillance and treatment for those with significant electrophysiological abnormalities could substantially lower the burden of subsequent morbidity and mortality. So what I have shown you is these are the types of injuries can happen into the heart, starting from hypotension, type 2 myocardial infarction, hypoxia, myocarditis, AC-mediated injury, coronary vascular ischemia, cytokine storm, stress cardiomyopathy, adrenergic stimulation, tachyarrhythmias, and coagulopathy. But this is a very important slide. See, these are the things that I have already enumerated, the type 2 AMI, where there is oxygen supply-demand mismatch, or it acute STEMI, thromboembolic manifestation, hyperadrenergic state, microembolic infarct, pro-inflammatory state like cytokine storm and other mediator, direct viral invasion, autoimmune disease, and interaction with the epicardial fat. That leads to myocardial injury, leading to myocardial infarction, microinfarct, ventricular fibrosis, or atrial fibrosis. And what it ultimately land to? One is the ischemic cardiomyopathy, or non-ischemic cardiomyopathy, or ventricular arrhythmias, or even the atrial fibrillation. But another important thing is the subclinical systolic and the diastolic abnormalities, which we have to pick it up. So treatment of COVID-19 infection included standard, novel, and the experimental therapy, we know. Now it is almost standardized. Now specific antiviral, anti-inflammatory, immunosuppressive, cell-based therapies still continue to evolve. Still, we do not know the exact treatment. But substantial number of patients who survive COVID-19, there is evidence for myocardial injury, and at the time of initial presentation may have long-term overt subclinical myocardial or electrophysiological abnormalities. It is unknown whether the severity of the cardiopulmonary injury, it is due to the type of treatment or any other host factor influence the long-term sequelae. Heightened surveillance is therefore warranted in this patient with consideration of the primary prevention approach. So it is essential to highlight the potential and cardiovascular and arrhythmic complication that may occur during the convalescent phase of survivor in COVID-19 infection. We know that there is a multi-mechanism and the pattern of injury. We know that 20-30% of hospitalized patients develop cardiac involvement with the troponin level. Patient with the COVID-19 with elevated troponin level without history of cardiovascular disease were associated with the malignant arrhythmias, acute respiratory failure, even the higher mortality. Interestingly, patient with the known cardiovascular disease but without elevated troponin level had a more favorable outcome. That is very important thing to note. After cardiac injury, potency, worse prognosis, greater need for mechanical ventilation, and the higher mortality. So there are certain papers, the C et al. Reported the cardiac injury was associated with the acute respiratory distress syndrome, acute kidney injury, and the coagulation disorder. Where the coagulation disorder and the metabolic derangement with acute kidney injury can also contribute to cardiac injury. Other mechanism we have already explained. But the arrhythmia risk in patient with the COVID-19 is multifactorial. It is related to viral infection, severity of the illness, severity of the cardiac injury, inflammation, and the potential drug treatment with the QT prolonging drugs. However, The presence of ventricular arrhythmias is higher in patients with the elevated troponin level, that is up to 17% compared with the 1.2% in patients without elevated troponin levels. So Lazarini and colleagues demonstrate the direct effect of the inflammatory cytokines, including the interleukin-6, have an HRGK1 channel, which prolongs ventricular action potential during the duration, leading to the lethal ventricular arrhythmias. Therefore, patients with the acute segment, ST segment MI and the COVID-19 may be expected to have larger infarcts if fibrinolytic therapy does not result in timely and complete reperfusion. And given the high prevalence of cardiac injury, it is reasonable to expect that a spectrum of heart disease is present with some residual post-myocarditis abnormalities. In fact, the recent media reports have already suggested some patients suffer from new onset cardiomyopathy during the convalescent patient after the COVID-19 infection. But presently, there is no robust long-term data. It is yet to come. It is only 1-year-old disease. The long-term COVID-19 cardiovascular complication. For patients with the acute coronary syndrome and the type 1 infarction, standard follow-up and the care is always followed like any other study. Patient with the type 2 MI, where there is a supply-demand mismatch with evidence for ischemia and the cardiac injury, elevated troponin level, and no evidence for ischemia, were compared with the patient with the type 1 MI during the 5 years follow-up. But they found the patient with the type 2 MI or cardiac injury had significantly higher rate of major cardiovascular events after adjustment of clinical covariates and higher rates of non-cardiovascular death. And these data would be relevant for a patient recovered for COVID-19 associated cardiac injury. There are a certain other mechanism is the microemboli, and the microvascular coronary dysfunction has been described as one of the mechanisms of acute coronary injury during COVID-19. See, the microemboli have been described, but there are no studies that have specifically evaluated the burden of arrhythmias post-myocarditis other viral during the follow-up, particularly in patients whose ventricular function has been recovered. In one study of long-term survival of 112 patients with biopsy-proven myocarditis, an ejection fraction of 40% was only a borderline predictor of mortality, suggesting that a substantial number of patients with the preserved left ventricular function died during follow-up. So we cannot forego this. Even the autopsy series of patients with the sudden cardiac death identified myocarditis as a potential explanation in a significant number of cases, even with a grossly normal appearing heart. So the finding of myocarditis is a significant cause of sudden death in the young is notable and the relevant to survivor to COVID-19. While myocarditis is typically considered for its manifestation on the ventricle, the atrium might be. Atrium, even the right ventricle is also involved. Another important factor is noted is the obesity. Why? As being observed to be a risk factor in outcome of COVID-19 infection. AC2 is expressed in adipose tissue. So recent publication point to a pathological link between COVID-19 and obesity. Obesity modulates inflammatory response through secretion of the pro and the anti-inflammatory adipokines and the modulation of the interleukin-6. Therefore, COVID-19 infection and its interaction with the adipocyte may contribute to deleterious outcome. Even the inflammation involving the epicardial adipose tissue may be affected, that is the EAT, by the myocarditis because of the contiguity of the myocardium and the epicardial adipose tissue. See, the epicardial fat has been linked with atrial fibrillation and even the coronary artery disease. Hence, the COVID-19 interaction with the epicardial fat may be possible to link to acute and long-term atrial fibrillation and the coronary artery disease. So it is more important in the atrioventricular group and the lateral LV wall, closer to the basal segment. It is very important why I'll tell you in the later slides. The loss of AC2 has been shown to result in heart failure with preserved ejection fraction, mediated in part by EAT inflammation. The severe acute respiratory syndrome, coronavirus 2 binding of AC2 may occur prominently where there is areas of high fat, high EAT, such as the basal LV, causing subclinical dysfunction via inflammatory downstream effect, perhaps more readily in overweight and obese patients. There is much unknown about COVID-19 infection. A lot of things we do not know, just like entities with acute cardiac injuries. But based on other studies of patients with recovered myocarditis, type 2 AMI, and other cardiac injuries, it is expected that some patients will have subclinical and possibly overt cardiovascular abnormalities. Patients with ostensibly recovered cardiac function may still be at risk of coronary artery disease, atrial fibrillation, and the lethal ventricular arrhythmia. Now, what is the now current paradigm? While the current paradigm for treatment appropriately focus on the acute recovery, we do not know that a long-term follow-up. It is unknown whether the treatment given during the acute illness may even affect the future cardiovascular abnormalities. We do not know. And given the size of the pandemic, it is important that I have shown in the first slide to determine whether the acute delivery of the antifibrotic therapy, anti-inflammatory therapy, cell-based therapy, or even the antiviral therapy affects the long-term as well as the short-term outcomes. And so it is the need for optimal screening for patient after recovery from COVID-19 is very, very important. One paradigm would be to define the population with the highest risk by identifying patients with the COVID-19 infection and elevated high sensitivity troponin or the brain activity peptide level, as this has already been shown to provide important short-term prognostic information. So these patients should be followed to monitor and assess the long-term prognostic effect of COVID-19 myocardial involvement. So these are in a nutshell, the chart of the COVID-19 suspected or confirmed. You do the cardiac ultrasound in each and every case and find out what is the pathology and treat accordingly. So there is no dispute here. But here is the importance is there. So in acute cases, you measure the troponin, measure the BNP. If it is elevated, then it is a STEMI. Then you treat standard STEMI treatment and protocol for COVID-19 patient. If there is other evidence of myocardial injury, then you do standard imaging and therapy as clinical indicated. But when you go to the convalescent phase of 2 to 6 months, very, very important, you do ECG and echo, normal baseline, then cardiac monitoring, and consider patient for other risk factor. If it is abnormal, then you must do the two things. That is very, very important. Either echo with the strain, mainly the global longitudinal strain, and LG with MRI scan, and treat as clinically indicated. And of course, the standard TEMI will be like standard post-type therapy and the imaging considered the mixed IC. Now, screening for residual cardiac involvement in the convalescent phase is needed to establish the population burden in the long-term cardiac disease contributed by COVID-19. So if a significant burden of disease is identified, then trials of prophylactic therapy to prevent the long-term complication may be appropriate. The type of testing, cost effectiveness of the screening test for post-COVID-19 myocardial dysfunction and arrhythmia will need to be determined. And it is recommended to do standard electrocardiogram and the echocardiogram recording and probably the cardiac monitoring for 2 to 6 months post-recovery. Even these tests may not detect subtle clinical abnormalities. So even whenever there is any suspicion, then you do especially the overt or the subclinical myocardial dysfunction, recurrent pattern, the basal. So what do we see actually that? Recurring pattern of reduced basal left ventricular longitudinal strain. That is the mainly involved on speckle tucking echocardiogram in the hospitalized patient with the COVID-19 and subsequently aim to identifying the characteristics in the affected patient even in the recovery state. That technique is very well known. I am not going to explain the speckle tucking echocardiography, but patient with the COVID-19 with reduced basal LV strain would demonstrate elevated cardiac biomarkers. And GLS is very, very sensitive in this way to detect the left ventricular dysfunction compared with any other LV method like LV ejection fraction. And we do the bullseye polar eye map. And of course, we can do the segmental longitudinal strain patterns can be helpful in identifying the cardiac disease. Now, there is a study, one study in 81 patients with the COVID-19 who underwent the speckle tucking echocardiogram. Of this patient, 52% had a reduced basal strain on ST. That is, you can see the basal, the LVF was similar between this group. However, the GLS is different, 39% by versus 401% and 18%. So additional echocardiographic variables should be measured along with this GLS, like diastolic function, right ventricular function, but they were not different. Cases with the higher body mass index, prevalence of hypertension, the diabetes mellitus are more prone to develop. Levels of troponin 1 and the proBNP trended higher in cases, but are not statistically different from controls. So inflammatory markers and the clinical outcomes are similar between these two groups. So what they have shown that polar map displaying the regional strain pattern on TT in patient with the COVID-19, composite strain for display of 6 representative patients with the COVID-19 found to have a recurrent pattern of reduced LS in the basal segment. You can show all the cases you are seeing the basal segment of the left ventricle. Now I'll give you my few cases. This is a 40-year-old lady, non-diabetic and non-hypertensive, treated with the standard therapy and the high flow oxygen, recovered within 14 days and the discharge. Bedside echocardiography and the troponin level was reported normal. Presented 1 month after discharge with persistent weakness, and presently lab parameters were all normal. You can see the well-preserved ejection fraction of the 4th chamber, 2 chamber, and the 3-chamber view, and the GLS is absolutely normal of 22%. So these patients, this weakness may not be related to some cardiac involvement. Probably you can conclude, and this patient was on follow-up and nothing else. But see in the case number 2, this is a 52-year-old man, non-diabetic and non-hypertensive, treated with the standard therapy, high flow oxygen, recovered within 21 days and discharged. Bedside echocardiography and the troponin level was reported normal. Presented 15 days after discharge with persistent weakness and the dyspnea on exertion. Presently lab parameters were normal. See, here is the ejection fraction, again is absolutely normal ejection fraction. And you see the GLS is near about minus 17%. So there is a mild reduction of the GLS compared to his previous one of 21. So these patients may be, some myocarditis is still ongoing. But taking the case number 3, this is a very interesting case, 48-year-old man, well-controlled diabetic and non-hypertensive, treated with the standard therapy and the high flow oxygen, recovered within 10 days and discharged. Bedside echocardiography and the troponin level was reported normal. Presented 21 days after discharge with respiratory distress and hospitalized again. Presently lab parameters, raised CRP, increased troponin level. And you see, ejection fraction is still maintained. And still maintained is a fantastic ejection fraction. And even in all the views, and you see the global longitudinal strain is only 10%. So these are the patients you can detect very early with the global longitudinal strain. Case number 4 is more interesting. 60-year-old man, hypertensive and non-diabetic, angioplasty done at LAD after acute anterior wall MI. Patient was doing well for the next 6 months. In the meanwhile, echocardiography was LVF 40% with kinetic ventricular septum and anterior wall in the median apical region. But developed COVID-19 infection, admitted with the respiratory distress and discharged in a stable condition after 14 days. Presently complain of dyspnea extension and referred to our lab for echocardiography. See, the anterior wall is still akinetic or hypokinetic you can call, but akinetic or hypokinetic, but cavity has been dilated and you see the global ejection fraction is near about only 9%. Not only the anterior wall and these are the akinetic area, all other basal areas also started reducing the ejection fraction, which was absolutely normal before that COVID. In fact, I have studied almost more than 200 cases that has yet to be compiled. So I can give you a preliminary report of total 96 I have evaluated. There's a criteria for selection is that all patients are COVID-19 positive detected by RT-PCR. All the patients are evaluated 2 to 4 weeks after discharge or after RT-PCR negative in home isolation. Age groups are 18 to 80 years. Sex ratio 58 to 36. There are comorbidities and yet to define the comorbidities and to differentiate without and all. There is a hypertension, diabetes, and IHD. all patients, the most important thing, the baseline echocardiogram and LV ejection fraction was normal, presenting symptoms of weakness and dyspnea on exertion. I have divided these into three groups, where the GLS is more than 80%, GLS 14 to 18%, and GLS is less than 14%. Because less than 14% is that there is a definite involvement due to the COVID involvement. So what we find in the group 1 is the gist is that GLS, where there is a more than 18% of the relatively young patient, less hospital stay, or in the patient in the home isolation, and minimal or no comorbidities. You can see that glimpse of 8 patients I can give it from that group. Say almost more than 18% are all normal. Then in the group 2, GLS 14 to 18%. These are basically the aged patient with the comorbidities and the prolonged hospital stay. And you can see all these things between 14 to 18%, where there is mainly the basal involvement is there, but apex and all these things are not involved. And the last group, where GLS is less than 14%, we found the middle-aged and old patient with the multiple comorbidities or prolonged and stormy ICU stays, where you can see even not only the basal part, and all are below 14%, even some are 7 to 8%, and all even the apical part and other part are also involved. Middle part are also involved. So these findings support studies showing LV-GLS is a measure of sensitive marker of early myocardial dysfunction, then LVF in the early course of convalescence phase in COVID-19. Of course, now the report is coming. There is a latest report is coming. Even the abnormalities in the RV strain, even the LS strain, and LV-GLS have also been reported to indicate subclinical myocardial injury. Importantly, cardiac magnetic resonance imaging in a significant proportion of recovered patients with the COVID-19 revealed fibrosis and edema predominant in the basal and the mid segment, corresponding with the speckle tracking echocardiography. And the basal injury pattern reflect the susceptibility of certain myocardial lesion to inflammatory on the systemic stressor, not due to geographic predilection specific to severe acute respiratory syndrome coronavirus. Further supporting this theory, a study showing apical sparing LV dysfunction in patients with the acute brain hemorrhage. The associated catecholamine surge in these critical scenarios may also contribute to cardiac injury in COVID-19. Hence, the need for advanced imaging, that is MRI with gadolinium enhancement, or the echocardiography strain, especially the speckle tracking echocardiography and the global longitudinal strain, when initial testing reveals abnormality or during monitoring as the clinically indicated. Future studies will clarify whether there will be post-COVID-19 cardiac syndrome, how best to manage the patient recovering from COVID-19's cardiac involvement. We are currently facing a pandemic unseen in our lifetime, with potential long-term cardiovascular complications. Now is the time for Accent to plan appropriate registries and clinical studies to assess the incidence and significance of potential mid and long-term cardiac abnormalities and dysrhythmias, with the hope and to promise to mitigate these long-term sequelae. Thank you.